Good morning all. Today we shall discuss about PIT and fissure sealants. In our day-to-day practice, we all would have come across PIT and fissure caries or occlusal caries. Even though the prevalence of dental caries in developed countries has declined, the occlusal caries of primary and permanent dentition continues to be a problem for children. And the highest prevalence of pit and fissure caries can be attributed to the architecture of pits and fissures. Now let's see how the morphology of pit and fissure can contribute to the occurrence of occlusal caries. According to Nagano's classification, there are 5 major types of occlusal pits and fissures. They are V, U, I, inverted Y, and IK. Among these, we can see that U and V are quite wide and shallow, which make them self-cleansible and caries resistant, while I, Y and IK type are quite narrow and deep. This narrow slit-like opening and a large base towards the DEJ make them more caries susceptible. Pits and fissures that are narrow or have a constricted opening are difficult to clean even with vigorous brushing. This figure shows that this toothbrush bristle is too large to remove bacteria and food debris that are entrapped in the deep fissures. Hence, use of sealants act as a physical barrier preventing oral bacteria and dietary carbohydrates from aggregating within the deep pits and fissures and thus prevents the development of caries. In the history of prevention of caries, both conservative and invasive attempts have been made by various authors from 20th century onwards. In 1895, zinc phosphate cement has been used as a sealant material by Wilson. In 1942, Klein and Knudsen used ammoniacal silver nitrate to seal pits and fissures. In 1923, Hayat advocated a new procedure known as prophylactic odototomy, in which he advocated filling the fissures of the uh, teeth with silver or copper oxyphosphate cement as soon as the tooth erupts into the oral cavity. Later on complete eruption, the small occlusal cavities are prepared on the tooth and it is filled with silver amalgam. In 1929, Hodaker suggested the whitening of fissures mechanically so that they would be less retentive to food particle and they will become more self-cleansable. And the procedure he named it as fissure eradication. In 1955, Unicor introduced a new method of acid etching, thereby resins can be adhered onto the tooth surface. Now, indications for pit and fissure sealants. The first indication for placement of a pit and fissure sealant is deep retentive pits and fissures that has wedging or catching of the explorer. Also, the sealants can be placed on newly erupted primary molars, permanent bicuspids and molars, but with complete recession of pericoronal operculum, because with the operculum, it is difficult to isolate and also it interferes with the sealant placement. Stained pits and fissures are also a good candidate for pit and fissure sealants, but it should be kept in mind there should not be any if it is present, it should be minimum decalcification or opacification of these fissures, and there should not be any softness at the base of the fissures. Sealants can also be placed on questionable enamel caries on pits and fissures. Apart from these indications, the more realistic approach is to judge the individual caries risk. Risk assessment can be done based on the age, oral hygiene, familial and individual history of caries, fluoride environment and history, dietary habits, tooth type, and morphology. Based on the caries risk assessment, the patient can be categorized into low, moderate, and high risk. And the pit and fissure sealant can be given to the patients with moderate and high risk of developing caries. Coming to the contraindications, there are no absolute contraindications for pit and fissure sealant placement. However, some relative contraindications include individuals with no previous caries experience and with well-coalesced pits and fissures. Also, wide and self-cleansible pits and fissures are contraindicated for sealant placement. Pits and fissures that have remained caries-free for 4 years or longer can also be excluded. Tooth that cannot be isolated and partially erupted tooth is difficult to seal. So it is also contraindicated as a pit and fissure for pit and fissure sealants. However, GIC sealant can be used in such cases with partially erupted tooth and the tooth which is difficult to isolate. Now, requisites of an efficient sealer. Breuer in 1978 has put forward certain requisites for an sealant to be efficient. First one is that the sealant should be viscous enough so that it allows the penetration of the sealant into the narrow fissures even in the maxillary teeth. And the sealant should have adequate working time, and it can be rapidly cured, and it should have a karyostatic action. The sealant that we use should have good and prolonged adhesion to the enamel, and also it should have low sorption and solubility. It should be resistant to wear, and it should not cause, or it should cause only minimum irritation to the adjacent tissues. Now coming to the classification of pit and fissure sealants. Currently, 2 types of sealants are available: resin-based sealant and glass ionomer-based sealant. Resin-based sealants are the most commonly used sealants. Glass ionomer sealants are generally recommended for partially erupted tooth or when the isolation is difficult. Historically, pit and fissure sealants have been classified by various authors, and one such classification put forward by Michel and Gordon is as follows. They classified pit and fissure sealants based on the polymerization method, based on the presence of filler, and based on the color. Based on the polymerization method, the sealants can be classified into 4 generations. First generation is the sealants that can be polymerized with UV light. Second generation is the self-cured or chemically cured sealants. Third generation is the sealants that can be polymerized by visible light. And fourth generation is the fluoride-releasing sealants. Based on the presence or absence of filler, the sealants can be classified into unfilled and semi-filled or filled. Unfilled sealants will be having better flow, while the semi-filled or filled sealants will be stronger and they are resistant to wear. Based on the color, the sealants can be classified into tinted and clear. Tinted sealants are easy for identification, whereas clear sealants are difficult to detect. Colored sealants are more advantageous than the clear sealants because it is easily appreciated by the patient and can be monitored by the dentist at the subsequent recalls. And thus, the sealant loss can be easily assessed by using colored sealants. Clinical technique for sealant placement. First, for the placement of the sealant, the first step is to cleanse the tooth surface. For cleaning the tooth surface or prophylaxis of the tooth surface can be done using pumice slurry that can be applied with a rubber cup or pointed bristle brush rotating at a slow speed handpiece. Toothbrush prophylaxis with toothpaste or pumice with copious water rinsing is another option for cleansing the tooth. Air polishing device using an air abrasive can also be used for cleansing the tooth surface. However, it should be noted that flavored, oil-based or fluoride-containing prophylaxis paste is not recommended as it adversely affects the enamel conditioning. After cleansing the tooth is rinsed thoroughly. And trace the pits and fissures with sharp and fine explorer to remove any remaining cleansing agent lodged within them. If sodium bicarbonate slurry is used, neutralize it with phosphoric acid for 5 to 10 seconds, after which rinse and air dry the tooth surface. The second step is to isolate the tooth from the saliva and clavicular exudate contamination. For isolation, either we can use a rubber dam or cotton roll isolation with adequate suctioning can also be used. After isolating the tooth surface has to be etched using an etchant. The etchant can be a liquid or a gel. It is advantageous to use a gel as it has increased control over the areas to be etched. And the etching agent can be applied using fine brush, cotton pledget, or mini sponge. The most commonly used etching agent is the phosphoric acid in 35 to 40% concentration with an application time of 15 to 60 seconds. It is recommended that for permanent tooth, 15 seconds of etching time is adequate, and for the primary tooth, it can be extended to 15 to 30 seconds. Whereas for the fluorose tooth, an additional etching time has to be given. After acid etching, there will be some porosities present on the tooth surface that helps in the resin tag formation. This etched enamel surface histologically shows three zones, which is the etch zone, qualitative porous zone, and quantitative porous zone. After etching the tooth surface, rinse and dry the tooth surface with air and water syringe for 30 seconds. This is to remove etchant and the reaction products. After rinsing, dry the tooth with uncontaminated compressed air for 15 seconds and check for frosted appearance. If the frosted appearance is not seen, repeat the etching step for another 10 seconds. If the salivary contamination occurs, rinse the tooth and again re-etch. It is recommended to use a hydrophilic bonding agent prior to the sealant application if the total isolation is not possible. After the etching and drying the surface, apply the sealant to the etched tooth surface. For the mandibular teeth, apply at the distal aspect and allow it to flow mesially. For the maxillary tooth, apply at the mesial aspect and allow it to flow distally. Prevent incorporation of air into the material and creation of voids while applying the sealants. Carry a thin layer of sealant up to the cuspal inclines to seal the secondary and supplementary fissures. Also, flow the sealant material into the buccal and lingual pits and grooves. After the application of sealant, cure the sealant for polymerization. Now, after the curing the sealant, explore the sealed tooth surface to check for any voids in the material. If there are any deficiencies are present, apply additional sealing material. Now, remove the rubber dam and cotton rolls. Now, finally, evaluate the occlusion of sealed tooth surface and interproximal discrepancies. The small discrepancies in the occlusal interference seen in an unfilled sealant is easily tolerable by the child patient because the sealant will abrade away. While with the filled sealant material and in adult and adolescent age group, occlusal adjustment should be completed to avoid discomfort. Now, evaluate the interproximal regions using an explorer or by passing a dental floss between the contact region for any inadvertent sealant placement. Finally, we have to periodically reevaluate and reapply sealant as necessary. Usually, the reevaluation of the sealant should be done periodically, and we have to check for any sealant loss, exposure of any voids, and exposure of we have to check for any further caries development. Usually, the need for reapplication is highest during the first 6 months after placement. Now, recent advances in PIT and fissure sealants. First one is the fluoride releasing sealants. The fluoride releasing sealants show a release of prolonged fluoride release of prolonged period and promote fluorapatite promotion. formation and thus produce caries prevention. Examples of fluoride releasing sealants include Seal Right, Conceal Left, and Fluoroshield. Second one is colored PIT and fissure sealants. This type of sealant is clear to begin with, but it changes color after polymerization. And this degree of color change is almost an indicator of its setting and adequate polymerization. This kind of sealant is easy to see during placement, and on our recall, we can evaluate a sealant loss more easily. Example of this color PIT and fissure sealant is Clean Pro, which changes to pink on setting. Next comes fluorescing PIT and fissure sealants. Through use of a UV pen light, this sealant fluoresces a blue or white color. It helps in easy verification and identification of sealant margins, retention during recall appointments. Example of fluorescing PIT and fissure sealant include Dept Seal and Glow. Next is the moist bonding PIT and fissure sealants. We all know that conventional resin-based sealant is very technique sensitive as they are hydrophobic and require a dry field. Hence, this moisture tolerant resin sealant came into being that can be applied in a wet field. Example of such kind of sealant is Embrace Wet Bond. Advantages of this sealant include wet bonding, no marginal chipping, and there is no need of applying a bonding agent. This type of sealant contains hydrophilic resin, whereas the other conventional sealants contain bisphenol A or bis-GMA or bis-DMA, which are hydrophobic resins. Last but not the least, the most recent advance in the PIT and fissure sealant is the PIT and fissure sealant with ACP. ACP means amorphous calcium phosphate. Amorphous calcium phosphate is a newer remineralizing agent that releases calcium and phosphate ion, and that helps in remineralization of the tooth surface. Example of such kind of sealant is Aegis sealant. So to conclude, we can summarize that PIT and fissure caries represent approximately 90% of the total caries experienced in the childhood and adolescent. With the introduction of sealants, a clinical approach for prevention of caries in PIT and fissures became available. These sealants are placed to prevent caries initiation and to arrest caries progression by providing a physical barrier that inhibits microorganisms and food particles from collecting in pits and fissures. Therefore, sealant use should be increased along with other preventive interventions to manage the caries disease process, especially in patients with elevated risk of developing caries. Thank you.